Welcome to the Medical Licentiate Emerson channel. Today we will go through systemic lupus erythematosus, or SLE for short. SLE is a chronic, multisystem, inflammatory disorder of autoimmune etiology, occurring predominantly in young women. Starting with introduction, of all cases of SLE, 70 to 90% occur in women usually of childbearing age. Systemic lupus erythematosus, SLE, is more common and severe among Black and Asian patients than among white patients. It can affect patients of any age, including neonates. In some countries, the prevalence of SLE rivals that of rheumatoid arthritis. SLE may be precipitated by currently unknown environmental triggers that cause autoimmune reactions in genetically predisposed people. Some drugs e.g., hydralazine, procainamide, isoniazid, anti-tumor necrosis factor (TNF) drugs cause a reversible lupus-like syndrome. Clinical findings vary greatly. SLE may develop abruptly with fever or insidiously over months or years with episodes of arthralgias and malaise. Vascular headaches, epilepsy, or psychoses may be initial findings. Manifestations referable to any organ system may appear. Periodic exacerbations, flares, may occur. Joint symptoms, ranging from intermittent arthralgias to acute polyarthritis, occur in about 90% of patients and may precede other manifestations by years. Most lupus polyarthritis is non-destructive and non-deforming. However, in long-standing disease, deformities without bone erosions may develop, e.g., the metacarpophalangeal and interphalangeal joints may rarely develop reducible ulnar drift or swan neck deformities without bony or cartilaginous erosions, jack-out arthritis. As in many other chronic diseases, the prevalence of fibromyalgia is increased, which may cause diagnostic confusion in patients with periarticular and generalized pain and fatigue. Skin lesions include malar butterfly erythema, flat or raised, that generally spares the nasolabial folds. The absence of papules and pustules and presence of skin atrophy help distinguish SLE from rosacea. A variety of other erythematous, firm, maculopapular lesions can occur elsewhere, including exposed areas of the face and neck, upper chest, and elbows. Skin blistering and ulceration are rare, although recurrent ulcers on mucous membranes, particularly the central portion of the hard palate near the junction of the hard and soft palate, the buccal and gum mucosa, and the anterior nasal septum, are common, sometimes called mucosal lupus. Findings can sometimes mimic toxic epidermal necrolysis. Generalized or focal alopecia is common during active phases of SLE. Paniculitis can cause subcutaneous nodular lesions, sometimes called lupus paniculitis or profundus. Vasculitic skin lesions may include mottled erythema on the palms and fingers, periungual erythema, nail fold infarcts, urticaria, and palpable purpura. Petechia may develop secondary to thrombocytopenia. Photosensitivity occurs in some patients. Lupus erythematosus tumetis is characterized by pink to violaceous urticarial non-scarring plaques and/or nodules, some annular, in light-exposed areas. Chilblain lupus is characterized by tender, bright red to reddish-blue nodules on the toes, fingers, nose, or ears that occur in cold weather. Some patients with SLE have features of lichen planus. Raynaud syndrome due to vasospasm in the fingers and toes causes characteristic blanching and cyanosis. Cardiopulmonary manifestations. Cardiopulmonary symptoms commonly include recurrent pleurisy, with or without pleural effusion. Pneumonitis is rare, although minor impairments in pulmonary function are common. Diffuse alveolar hemorrhage occasionally occurs. Prognosis has traditionally been poor. Other complications include pulmonary emboli, pulmonary hypertension, and shrinking lung syndrome. Cardiac complications include pericarditis, most commonly, and myocarditis. Serious, rare complications are coronary artery vasculitis, valvular involvement, and Liebman-Sachs endocarditis. Accelerated atherosclerosis is an increasing cause of morbidity and mortality. Congenital heart block can develop in neonates whose mother has the antibodies against RO-SSA, or LA-SSB. Hope we are together so far. Generalized adenopathy is common, particularly among children, young adults, and Black people. However, mediastinal adenopathy is not common. Splenomegaly occurs in 10% of patients. Neurologic symptoms can result from involvement of any part of the central or peripheral nervous system or meninges. Mild cognitive impairment is common. There may also be headaches, personality changes, ischemic stroke, subarachnoid hemorrhage, seizures, psychoses, aseptic meningitis, peripheral and cranial neuropathies, transverse myelitis, chorioathetosis, or cerebellar dysfunction. Differentiation between corticosteroid-induced psychosis and neuropsychiatric lupus can be challenging because neither is associated with marked abnormalities in the cerebrospinal fluid, CSF, or on routine imaging. Renal involvement can develop at any time and may be the only manifestation of SLE. See lupus nephritis on our channel and don't forget to subscribe if you are enjoying this video. For more, it may be asymptomatic or progressive and fatal. Renal disease can range in severity from a focal glomerulitis to a diffuse, potentially fatal membranoproliferative glomerulonephritis. Common manifestations include proteinuria, most often, an abnormal urinary sediment manifested by red blood cell casts, hypertension, and edema. Early lupus glomerulonephritis may be misdiagnosed as asymptomatic urinary tract infection. Obstetric manifestations include early and late fetal loss. In patients with antiphospholipid antibodies, the risk of recurrent late miscarriages is increased. Pregnancy can be successful. See SLE in pregnancy on our channel, particularly after 6 to 12 months of remission, but SLE flares are common during pregnancy and especially during the postpartum period. Planned pregnancy should be timed for when disease is in remission. During pregnancy, the patient should be monitored closely for any disease flare or thrombotic events by a multidisciplinary team that includes an obstetrician who specializes in high-risk pregnancies. Women who are SSA antibody positive should have weekly fetal ultrasonography between week 18 and week 26 to assess for congenital heart block. Hematologic manifestations include anemia, anemia of chronic disease, autoimmune hemolytic anemia, leukopenia, usually lymphopenia, neutropenia, or both, and thrombocytopenia, usually mild but sometimes life-threatening autoimmune thrombocytopenia, recurrent arterial or venous thrombosis, thrombocytopenia, and a high probability of obstetric complications occur in patients with antiphospholipid antibodies. Thromboses account for some of the complications of SLE, including obstetric complications. Macrophage activation syndrome is a rare but potentially life-threatening complication that can occur. Gastrointestinal manifestations can result from bowel vasculitis or impaired bowel motility. In addition, pancreatitis can rarely result from SLE. Manifestations may include abdominal pain resulting from serositis, nausea, vomiting, manifestations of bowel perforation, protein-losing enteropathy, and pseudo-obstruction. SLE rarely causes parenchymal liver disease. SLE should be suspected in patients, particularly young women, with any of the symptoms and signs. However, early-stage SLE can mimic other systemic rheumatic diseases, including rheumatoid arthritis if joint symptoms predominate. Mixed connective tissue disease includes, by definition, features of SLE as well as possibly features of systemic sclerosis, rheumatoid-like polyarthritis, and myositis. Infections e.g., bacterial endocarditis, histoplasmosis can mimic SLE and may develop as a result of treatment-caused immunosuppression. Disorders such as sarcoidosis and paraneoplastic syndromes can also mimic SLE. Laboratory testing may differentiate SLE from other systemic rheumatic diseases. Initial laboratory testing should include the following: anti-nuclear antibodies (ANA), extractable nuclear antigens (ENUS) if ANA test is positive, including anti-double-stranded dsDNA, anti-dsDNA, anti-Smith, anti-U1RNP, anti-ROSSA, and anti-LA-SSB antibodies. Complement C3 and C4 levels. Complete blood count (CBC). Urinalysis with urinary sediment. Chemistry profile including renal and liver enzymes. In clinical practice, some clinicians rely on the classification criteria for SLE developed by the European League Against Rheumatism, American College of Rheumatology (EULAR-ACR). See Table EULAR-ACR criteria for the classification of systemic lupus erythematosus. Patients are eligible for these criteria only if they have a positive ANA result is greater than or equal to 180. The 2019 EULAR-ACR classification criteria include clinical and immunologic domains, and each criterion is assigned a weight of 2 to 10. If the patient's score is 10 or more, and at least one clinical criterion is fulfilled, disease is classified as SLE. However, a positive ANA does not indicate a diagnosis of lupus. A positive ANA test in the presence of fatigue and generalized myofascial pain without other clinical or laboratory findings is rarely significant. ANA testing. Testing for ANA, preferably by indirect immunofluorescence rather than by a solid phase assay, is an appropriate initial test for patients with suspected SLE. A positive ANA test, usually in high titer, greater than 1/80, occurs in greater than 95% of people with SLE. However, a positive ANA test can also occur in rheumatoid arthritis, other systemic rheumatic diseases, autoimmune thyroid disease, multiple sclerosis, cancers, and even in the general population. The false positive rate varies from approximately 3% with ANA titers of 1/320 to approximately 30% for ANA titers of 140 among healthy controls. Medications such as hydralazine, procainamide, and tumor necrosis factor inhibitors can cause positive ANA results as well as a drug-induced lupus. The symptoms typically resolve after the medication is stopped. Positive ANA should prompt more specific testing such as anti-dsDNA antibodies. Anti-dsDNA is highly specific for SLE. Other ANA and anticytoplasmic antibodies. The ANA test is very sensitive, but it is not specific for SLE, thus, evidence of other autoantibodies is used to aid in diagnosis. The other autoantibodies are often referred to as extractable nuclear antigens and include dsDNA, Smith SM ribonucleoprotein RNP ROSSA, and LA-SSB. RO is predominantly cytoplasmic. Anti-RO antibodies are occasionally present in patients with ANA-negative SLE presenting with subacute cutaneous lupus erythematosus. Anti-RO is the causal antibody for neonatal lupus and congenital heart block. Anti-SM is highly specific for SLE but, like anti-dsDNA, is not sensitive. Anti-RNP occurs in patients with SLE, mixed connective tissue disease, and occasionally other systemic rheumatic disorders and systemic sclerosis. Other tests. Leukopenia, usually lymphopenia, and neutropenia, is common. Hemolytic anemia may occur, but low hemoglobin and red blood cell counts are more often due to the anemia of chronic disease. Thrombocytopenia in SLE may be difficult or impossible to differentiate from idiopathic thrombocytopenic purpura except that patients have other features of SLE and/or SLE-specific antibodies, anti-dsDNA or anti-SM. False positive serologic tests for syphilis occur in 5 to 10% of patients with SLE. These test results may be associated with the lupus anticoagulant and a prolonged partial thromboplastin time, PTT. Abnormal values in one or more of these assays suggest the presence of antiphospholipid antibodies, e.g., anticardiolipin antibodies, which should then be measured directly by enzyme-linked immunosorbent assay, ELISA. Antiphospholipid antibodies are associated with arterial or venous thrombosis, mild thrombocytopenia, and, during pregnancy, spontaneous abortion or late fetal death but may be present in asymptomatic patients. Other blood tests help monitor disease severity and determine the need for treatment. Serum complement levels C3, C4 are often depressed in active disease and are usually lowest in patients with active nephritis. Erythrocyte sedimentation rate ESR is elevated frequently during active disease. C-reactive protein levels are not necessarily elevated. High levels raise the concern for infection and/or serositis. Complete spirometry tests and an electrocardiogram are recommended in patients with respiratory symptoms. Renal involvement. Screening for renal involvement begins with urinalysis with urinary sediment. Red blood cell RBC and/or white blood cell casts suggest active nephritis. Urinalysis should be done at regular intervals, e.g., every 3 to 6 months, even for patients in apparent remission and without previous renal involvement, because kidney disease is usually asymptomatic. Proteinuria can be estimated by the urine protein-creatinine ratio or measured in a 24-hour urine collection. Renal biopsy is indicated in patients whose protein excretion is greater than 500 mg per day and who have hematuria, thought to be glomerular, or RBC casts, and is helpful in evaluating the status of renal disease, i.e., active inflammation versus chronic changes, and in guiding therapy. Classification of lupus nephritis is based on histologic findings on renal biopsy. See table classification of lupus nephritis. Repeat renal biopsy should be considered in some patients because switching from one class of lupus nephritis to another is common in patients with SLE. Patients with chronic renal insufficiency and mostly sclerotic glomeruli are not likely to benefit from aggressive immunosuppressive therapy. Treatment of SLE. Hydroxychloroquine, an antimalarial, for all patients with SLE. Nonsteroidal anti-inflammatory drugs NSAIDs, as needed in addition to antimalarials for mild disease. Corticosteroids, other immunosuppressants, and antimalarials for severe disease. To guide therapy, SLE should be classified as mild to moderate, e.g., fever, arthritis, pleurisy, pericarditis, rash or severe, e.g., hemolytic anemia, severe thrombocytopenic purpura, massive pleural and pericardial involvement, diffuse alveolar hemorrhage or pneumonitis, nephritis, acute vasculitis of the extremities or gastrointestinal tract, florid central nervous system (CNS) involvement. The antimalarial hydroxychloroquine is indicated for all patients with SLE regardless of disease severity because it decreases disease flares and decreases mortality. Hydroxychloroquine may also reduce thrombotic events, especially in patients with associated antiphospholipid syndrome. It must be avoided if there is an absolute contraindication because of adverse events, e.g., ocular toxicity. In addition, it should be used with caution if there is a history of glucose 6-phosphate dehydrogenase G6PD deficiency. Patients require routine monitoring during treatment to assess disease activity in response to therapy. In addition to clinical follow-up, disease activity can be assessed with the Systemic Lupus Erythematosus Disease Activity Index 2000 SLEDAI-2K and the British Isles Lupus Assessment Group BILAG Index. Mild to moderate disease. Arthralgias are usually controlled with NSAIDs. However, chronic NSAID use is discouraged because of gastrointestinal adverse effects, e.g., peptic ulcer disease and potential coronary and renal toxicity, e.g., interstitial nephritis, papillary necrosis. Topical agents, e.g., corticosteroids, tacrolimus, can be used for skin disease, usually under the guidance of dermatology. Antimalarials, such as hydroxychloroquine, are useful for joint and skin manifestations. Hydroxychloroquine reduces the frequency of SLE flares and decreases mortality, and is therefore used in virtually all patients with SLE. The dose is 5 mg per kilogram of actual body weight orally once a day with a maximum dose of 400 mg per day. Baseline ophthalmologic examination should be done before starting therapy to exclude retinopathy because chronic hydroxychloroquine use increases the risk of toxic retinopathy. Ophthalmologic screening should be done yearly to assess for retinal toxicity. Hydroxychloroquine can rarely cause skeletal or cardiac muscle toxicity. Alternatives include oral chloroquine 250 mg once a day and oral quinacrine 50 to 100 mg once a day. Methotrexate 15 to 20 mg orally or subcutaneously once a week, azathioprine 2 mg per kilogram orally once a day, or mycophenolate mofetil 1 to 1.5 grams orally twice a day, can be added to hydroxychloroquine in patients with uncontrolled mild to moderate disease who would otherwise be candidates for a course of corticosteroids. The ultimate goal is to maintain disease remission either without the need for corticosteroids or with only the lowest dose possible. Belimumab 10 mg per kilogram IV every 2 weeks for 3 doses, then 10 mg per kilogram IV once a month or 200 mg subcutaneously once a week, should be considered if patients have uncontrolled disease or frequent flares, particularly for joint, skin, renal, or non-severe hematologic manifestations. It can be used in addition to hydroxychloroquine and in combination with other medications depending on the specific system involved and severity of disease. Screening and monitoring for depression is required when initiating therapy with belimumab because of a possible risk of new onset or worsening depression and suicidality. If you are enjoying the content, please like and subscribe to our channel. Severe disease. Treatment includes induction therapy to control acute severe manifestations followed by maintenance therapy. Corticosteroids are first-line therapy. A combination of a corticosteroid and other immunosuppressants is typically used in active severe disease, i.e., lupus nephritis with impaired renal function, myocarditis, or CNS involvement. The complication for which there is the strongest evidence for treatment efficacy is lupus nephritis. Methylprednisolone 1 gram by slow, 1-hour IV infusion on 3 successive days is often the initial treatment, although trial evidence for this pulse corticosteroid therapy is lacking. Then, oral prednisone given in doses of 0.5 to 1 mg per kilogram once a day, usually 40 to 60 mg once a day, is initiated and the dose is adjusted according to the manifestation of SLE. Corticosteroids should be tapered as soon as allowed by the disease, usually within 6 months, to limit adverse effects. Cyclophosphamide, see Table IV. Cyclophosphamide protocols for systemic lupus erythematosus, or mycophenolate mofetil, up to 3 grams a day orally in 2 doses, is also used for induction therapy along with corticosteroids. Effective birth control, an intrauterine device, is typically preferred to hormonal approaches, as required when using mycophenolate mofetil and cyclophosphamide because of the risk of congenital malformations. Adding belimumab in a dose of 10 mg per kilogram IV monthly to corticosteroids and mycophenolate or corticosteroids and cyclophosphamide has been shown to lead to a better renal response and complete renal response at 6 months compared to corticosteroids and mycophenolate or corticosteroids and cyclophosphamide alone, especially if extrarenal manifestations are active. Voclosporin in a dose of 23.7 mg orally twice a day in combination with mycophenolate mofetil and a rapidly tapered course of corticosteroid has been shown to lead to better renal outcomes at 1 year than corticosteroids and mycophenolate mofetil alone. Both belimumab and voclosporin are now often being used in combination with mycophenolate to treat lupus nephritis, classes 3, IV, and V, but clear guidelines for their use are not yet available. Cyclophosphamide use for more than 6 months is discouraged because of potential toxicities, including infertility and increased risk of cancer. Once disease control is achieved, patients are transitioned to either mycophenolate mofetil, 1 to 1.5 grams orally 2 times a day, or azathioprine, 0.5 to 1.5 mg per kilogram orally twice a day, for maintenance. Women of childbearing age for whom cyclophosphamide is being considered should be informed about the risk of gonadal toxicity and offered a fertility consult for ovarian protection or egg harvesting when possible. In neuropsychiatric lupus, including transverse myelitis, treatment recommendations are based on anecdotal evidence, and options include IV cyclophosphamide or IV rituximab, e.g., 1 gram on day 1 and day 15 given at 6-month intervals in addition to a corticosteroid. First-line therapy for thrombocytopenia and hemolytic anemia includes moderate or high-dose corticosteroids, typically prednisone 1 mg per kilogram orally once a day, maximum 80 mg a day, along with an immunosuppressant azathioprine 2 mg per kilogram orally once a day or mycophenolate mofetil 1 gram orally every 12 hours. IV immune globulin 400 mg per kilogram once a day for 5 consecutive days or 1 gram per kilogram once a day for 2 days may be useful, particularly if high-dose corticosteroids are contraindicated, e.g., in patients with active infection. Rituximab is an alternative option for refractory cases. Patients with end-stage renal disease can undergo kidney transplantation, as an alternative to dialysis, with a successful outcome, especially if their disease has been in remission. Improvement of severe SLE often takes 4 to 12 weeks. Thrombosis or embolism of cerebral, pulmonary, or placental vessels requires short-term treatment with heparin and longer treatment with warfarin. If the diagnosis of antiphospholipid syndrome is confirmed, lifelong therapy, usually warfarin, is usually indicated. The initial target international normalized ratio is usually 2 to 3. Anifrolumab, Ig1 kappa monoclonal antibody to type 1 interferon receptor, at a dose of 300 mg IV every 4 weeks, may be added to standard therapy for the management of moderate to severe SLE, particularly in patients with severe skin disease. However, patients with active and severe neuropsychiatric or renal disease were not included in the pivotal trial. Use of CD19 chimeric antigen receptor (CAR T-cell therapy for the treatment of refractory SLE shows promise. Maintenance therapy. Chronic disease should be treated with the lowest dose of corticosteroids, e.g., oral prednisone is less than or equal to 7.5 mg once a day or its equivalent, and other medications that control inflammation, e.g., antimalarials, immunosuppressants, mycophenolate mofetil or azathioprine, to maintain remission. Treatment should be guided by clinical features primarily, although anti-dsDNA antibody titers or serum complement levels may be followed, particularly if they have correlated with disease activity in the past. However, anti-dsDNA antibody titers or serum complement levels may not parallel non-renal disease flares. Other pertinent blood and urine tests may be used to assess specific organ involvement. Calcium, vitamin D, and bisphosphonate therapy, see prevention of osteoporosis, should be considered in patients taking corticosteroids long-term. If combination immunosuppressive therapy is used, patients should be given prophylaxis for opportunistic infections, such as pneumocystis jirovecii, see prevention of pneumocystis jirovecii pneumonia, and vaccines against common infections, e.g., streptococcal pneumonia, human papillomavirus, influenza, COVID-19. Photoprotection is also an important measure to help prevent flares. Sunscreens with a sun protection factor (SPF) greater than 50 that block both UVA and UVB are recommended. Coexisting medical conditions in pregnancy. All patients should be closely monitored for atherosclerosis, and cardiovascular risk reduction is a key part of management. See treatment of atherosclerosis. Long-term anticoagulation is vital in patients who also have antiphospholipid syndrome and history of thrombosis. See also anticoagulants. Pregnant women should remain on hydroxychloroquine throughout their pregnancy, and low-dose aspirin is recommended as well. When clinical antiphospholipid syndrome is present, as manifested by prior thrombotic events, full anticoagulation therapy with low molecular weight or unfractionated heparin is advised. If the pregnant woman has positive antiphospholipid syndrome antibodies and prior late-stage fetal loss or recurrent first trimester miscarriages, prophylactic low molecular weight or unfractionated heparin can be considered during pregnancy and 6 weeks postpartum. When the patient has positive serologies but no prior obstetric or thrombotic events, recommendations are less clear. Co-management by a hematologist, an obstetrician who specializes in high-risk pregnancies, and a rheumatologist should be considered when managing these patients. Mycophenolate mofetil is teratogenic. Because of this teratogenicity and the known poor outcomes related to active SLE during pregnancy, women should ideally conceive after their disease has been in remission for 6 months or longer. If the patient needs to remain on immunosuppression, e.g., ongoing maintenance therapy for lupus nephritis, mycophenolate mofetil is usually switched to azathioprine at least 6 months prior to conceiving. Azathioprine and tacrolimus are considered safe during pregnancy. The choice of contraception method usually is based on multiple factors, including disease activity, risk of thrombosis, and patient preference. Concerning the prognosis, the course is usually chronic, relapsing, and unpredictable. Remissions may last for years. If the initial acute phase is controlled, even if very severe, e.g., with cerebral thrombosis or severe nephritis, the long-term prognosis is usually good. The 10-year survival in most high-resource countries is almost 90%. Improved prognosis is in part due to earlier diagnosis and more effective therapies. However, despite advanced therapy and improvement of the mortality rate, survival is still considered lower than general population because of premature cardiovascular disease, disease activity, end-stage renal disease, and infection. Key takeaway points. Joint and skin manifestations are common in SLE, but the disorder can also affect various organ systems, such as the heart, lungs, lymphoid tissue, and kidneys, and the gastrointestinal, hematologic, reproductive, and nervous systems. The European League Against Rheumatism, American College of Rheumatology (EULAR, ACR) criteria can be used to support the diagnosis of SLE. Among tests, use the highly sensitive ANA for screening, but use clinical findings and other laboratory tests, e.g., anti-dsDNA, anti-SM, to help support the diagnosis. Evaluate all patients for kidney involvement. Treat all patients with hydroxychloroquine and, for mild disease, NSAIDs as needed. Use corticosteroids for moderate or severe SLE and an additional immunosuppressant for active lupus nephritis, neuropsychiatric lupus, skin manifestations that do not respond to hydroxychloroquine, diffuse alveolar hemorrhage, vasculitis, recurrent serositis, or cardiac manifestations. Use corticosteroids at the lowest possible dose and use other medications to maintain remission. Thank you for watching Medical Licentiate Emerson channel.